Okay, good evening, surgeons. This is Dr. Naidu, and I'm running another mock online Viva in preparation for the FCS2 examinations coming up in October. This evening we only have 2 candidates available. One of the candidates is unfortunately on call tonight and not able to participate. So I'm now going to call our first candidate, Dr. Hassama, and start the Viva. Hello.
Good morning.
Hello. Hi, Dr. Asmal. How are you?
Yeah.
Hi, can you hear me clearly?
Hello.
Hi, can you hear me?
Yes, I can.
Okay, can you see the screen on YouTube?
No.
Just see if you can you see it now? Okay, good. We can't see your face. Can you just readjust your Skype camera to face up? That's better. Okay, good. Okay, you ready to start?
Just hold on a second. Yeah.
Okay, good. Okay, so first question is define an abdominal aortic aneurysm.
Sorry. Okay. Define an abdominal aortic aneurysm.
Yeah.
Well, it's defined as increase in size of the abdomen of the normal size. It should be about. It basically it includes all the layers of the wall of the vessel, and it has to be more than 1.5 times greater than the usual size of the aortic vessel.
Okay, and what absolute number would you use as a cutoff?
Well, 3 centimeters in general is considered as a aortic aneurysm.
Okay.
Only for operative purposes, one would consider around 5 centimeters in.
Okay, now we're coming to that. What do you define as if there's an enlargement between 2 and 3 centimeters? So less than 3 centimeters, but it's larger than normal. Upper limit of normal is usually considered to be 2 centimeters.
Not sure, but maybe it's abdominal aortic ectasia.
Correct, yeah. What is the etiology of AAA?
Well, you have genetic, you have inflammatory, you have a couple of the causes. We have
So that's more of a sort of classification. In terms of risk factors, can you give me some risk factors for patients that may have a AAA?
high blood pressure, cholesterol.
Yep.
Has been associated. Diabetes has been protective, actually. They tell you it's protective. Smoking, vascular collagen diseases, patients with Warfarin syndrome could be infective also with syphilitic.
Okay, anything age related to sex? Hi, can you hear me? Anything related to age or sex?
Well, males in general have a higher, so greater than 60 years old,
Mm-hmm.
and surveillance actually recommended at least once in greater than 65 years old, and patients who have had smoking history.
Okay. What are the clinical features of a AAA?
Clinical features. Well, you can have like a mass associated in the abdomen, could be symptomatic, asymptomatic presentation. You can have like patients presenting with trash food syndrome. They can have like a different place can have an aneurysm, like in a popliteal region. You can have associated aneurysm.
Mm-hmm. So this, tell me more about this abdominal mass. What are the clinical features?
So you can have like a symptomatic or an asymptomatic mass. It could be pulsatile mass on examination.
Mm-hmm.
You can have.
Is there something more specific than pulsatile? Pulsatile, for example, let's say the patient had a pseudocyst of the pancreas and that's sitting on the aorta. That could be pulsatile. How would you differentiate that from a clinically from a AAA?
Well, it basically it enlarges on all sides.
Mm-hmm. What's that called? There's one term for it. It's not pulsatile. It may be pulsatile, but there's something specific. It's a specific clinical description.
I can't seem to remember.
Okay. How are AAAs diagnosed?
Usually by ultrasound, easiest.
Mm-hmm.
Sometimes on surveillance ultrasound, you can diagnose it
Mm-hmm.
clinically by examination.
Any other imaging?
Well, after you actually notice, you can have like a CT scan done as well, but one would not actually go straight to a CT scan unless we think that there's any role for intervention. So preoperative CT scan, you can have like an assessment of the aneurysm to see if there's
Okay.
to have like interventional procedures, which can be minimally invasive procedures.
Okay. Can you tell me what is the natural history of the AAA? And now this is where
Sorry,
this.
I couldn't hear you.
What is the natural history of?
I could.
Can you hear me?
Natural history.
Yeah,
Yeah.
natural history of a AAA in relation to the size, and you mentioned some cutoffs, measurements. Mm-hmm.
Well, in do you mean in terms of the follow-up? In terms of follow-up, one would like to.
Okay, so now that not exactly follow up. Sorry, natural history means what happens to abdominal aortic aneurysms. How do they progress in relation to the size? What is the natural history? Can you hear me?
Yes, I can hear you.
Oh, okay.
Um,
So natural history refers to
the,
what actually happens to the different sizes of aneurysm.
well, those which are actually greater than, if I'm not mistaken, those which are greater than than 4 to 5 centimeters, they would have a tendency to grow faster, and those which are smaller have a tendency to grow slower. But there were some studies that actually um, outlined that small aneurysms, like 2 to 3 centimeters, after 10 years, uh, they, uh, they could surpass, and they should be followed up because they can grow um, at a later stage.
So, what are you concerned about with the larger aneurysms? What happens to them?
Well, there's always a risk of of rupture,
Yes.
and so
So, what percentage are likely to rupture, and do you know any percentages?
yeah. mm, um, I I forgot about the percentages, but I know that um, I think from there's a range from 4 to 5, 5 to 6, and bigger ones have a higher percentage of rupture. We're talking about like 10% in 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 1 year, and it's a cumulative increase in terms of the size. So the bigger the aneurysm, you have like a higher risk of rupture.
Okay, and if an aneurysm does rupture, what is the overall mortality in that patient?
If it's outside of a hospital, it's more than it's quite high, more than 80%. Say inside the hospital, you have like a 50% chance of mortality.
Okay,
The patient comes in the hospital.
okay. What is the role of screening in AAAs?
Uh, Basically, the in the UK, having people have actually had aneurysm screen at the age of 65 with male smokers, um, and it has shown over the years that there is a decrease in mortality and morbidity associated with aneurysm rupture if these patients were followed up and treated early on in terms of an elective approach.
Is there a screening program in South Africa?
In South Africa, I don't think that there is any screening program at the moment.
Oh, okay. Briefly describe the UK small aneurysm trial. Have you heard of this trial?
Yeah, UK SAT trial.
Mm-hmm.
Um, I have heard of it. So mm, I can see my picture like at coming later, so I can see myself moving. UK SAT trial says that for aneurysm which are 2 to 3 centimeters, we don't need to screen it again, but one should have like a screen up at a later stage in 10 years to see if there's any change, and bigger aneurysms need to have uh, closer follow-up. Um, from 4 to 5 centimeters, they should have 6 monthly or yearly follow-up, and those which increase more than 1 centimeter, uh, and it also deals with those rapidly increasing aneurysm size. But
Okay.
yeah.
Did they give any specific recommendations about surgical intervention in the UK SAT trial?
In aneurysms greater than 5 centimeters, one should be able to explain the risk to the patient, and if there is interventional approach, one should actually consider. And smaller for females. So if for females, it's smaller aneurysm, 0.5 centimeters small.
Anything else in terms of surgical indications for surgery?
Rapidly growing aneurysms.
How do you define a rapidly growing aneurysm?
More than 1 centimeter growth in a year.
Correct. And any other parameters that you'd look at? So you mentioned size. It's actually more than 5.5 centimeters, not 5. You mentioned rapid growth. And is there anything else? So if it's less than 5.5 centimeters, but there's something else? Okay, let's move on. We're running out of time. Okay, what are the indications? No, we've done that already. How should patients with smaller aneurysms be managed? So less than 5.5 centimeters or less than 4 centimeters.
The small aneurysms. Well, one should have closer follow-up for this aneurysm to assess for the growth, and
So how do you surveil them? How do you monitor them?
6 monthly ultrasound.
Okay. What are the surgical options in treatment of AAAs? And briefly discuss the two options and list post-procedural complications of each.
One would have like an open procedure, and one could also consider for endovascular approach.
Correct.
And
Tell me a little about each of these procedures, and then I want you to focus on some of the post-procedural complications.
well, for the endovascular approach, you have like higher need for surveillance of this aneurysm post-procedure.
Sorry, you're breaking up. Hello?
Hello, can you hear me?
Yeah, I can hear you now. Just adjust your camera, please. Here. Yeah.
Sorry. So basically, you have like a higher need for surveillance of the post procedure after putting, if you're putting any type of endovascular procedure, you would have to have a closer surveillance of this aneurysm, to look for post-procedure endo leaks and all those. So these need to has a greater cost in terms of and a greater exposure to contrast media. So this patient also have like a greater need to have post-operative and longer surveillance for.
Okay. Before we get on your cap, that's fine with the post-procedural complications. What about the actual procedure? How would you select patients for EVA? What are the parameters that you would consider?
Well, you you have patient factors, and you would have the aneurysm factors. So we have to assess the patient to see if the patient would be fit for an open or an endovascular approach. If the patient is fit for endovascular, not fit for an open approach, one would consider also endovascular procedure. All these would involve monitoring patient's kidney function, monitoring if the patient's medical state, if the patient is fit enough to undergo open versus surgical. So the young patients would classify mostly for an open procedure, and the elderly, many of the elderly patients could classify for endovascular procedure.
Okay.
Also on.
That's fine. We're going to need to move on a bit. We're running out of time. Completely different question now. When is it safe to perform surgery in patients who are on warfarin therapy? At what INR level?
Well, one would like to attempt surgery before 1.5, INR less than 1.5.
1.2, okay. How should patients on warfarin be managed prior to elective surgery? So you've got a patient who needs an elective hernia repair. They are known cardiac valve replacement, heart valve replacement, and they are on warfarin therapy. So how would you prepare this patient prior to elective surgery?
The patient is on
warfarin therapy, chronic.
He's got a heart valve.
Yeah.
My approach would be basically look at to get my colleagues in for hematological colleagues as well to assess the patient, have a full cardiac examination, assessment prior.
You are managing this patient. You've got a patient here. You need to take them for an inguinal hernia repair, and they're on chronic warfarin therapy. So what are you going to do specific to the warfarin?
One should actually decide to put the patient on anticoagulation, like same.
So you're going to stop the warfarin. How long before?
It has to be. It takes about like 5 days. And in that meantime, you should actually transit the patient like same.
Okay. Is there anything you can do to speed up the reversal of the warfarin?
If the patient is on warfarin for like heart valve, I would be reluctant to stop the patient completely on like giving patient vitamin K or doing a like quick reversal.
Okay. No, that's fine. How should patients on warfarin be managed during emergency surgery? So this is a different setting now. Same patient now requires appendectomy.
Well, in that situation, one would think about like the priority. We have to try to do to start patient on an infusion, and then of anticoagulation, maybe heparin, and then try to and reverse warfarin while considering the surgery.
Okay, how can you reverse the warfarin?
You can give FFPs, and you can give cryoprecipitate.
Okay.
And
can give vitamin K.
Vitamin K as well.
Is there any other blood bank product that you're aware of that can reverse warfarin quite rapidly?
Factor 7? No. Yeah, it's just not coming to my mind at the moment.
Okay. Next, what is the problem with vitamin K treatment in these patients?
If you give vitamin K, then the reversal, it takes longer because it eliminates all the contents of vitamin, all the stores in the liver.
Mm-hmm.
So it will take longer for reversal.
Okay, good. Now, you said about putting the patient onto something like Clexane, which is a low molecular weight heparin. Before you operate, is it necessary to measure the activity of Clexane?
Before you...
So you've converted the patient from warfarin to Clexane. Do you need to, you're checking the INR with relation to the warfarin activity? Is it necessary to check any blood parameters in relation to Clexane before you would proceed to surgery? Obviously, you don't want the patient to bleed intraop.
One would check the APTT.
For low molecular weight heparin. Do we monitor patients on Clexane? Do we do any blood tests on them?
Not usually.
No. So it's not necessary. What is the effect of antiplatelet agents on surgery, aspirin and clopidogrel?
It would prevent clotting, and it can prolong bleeding.
Mm-hmm. So what would you do if you're worried? So this is now another patient, not on warfarin, not on Clexane, but taking aspirin.
I would assess the patient if there's any need for the antiplatelet, what the indications for the antiplatelet. If at least has been done very if it has been done around the surgery, or if it can be withdrawn or not, like prior to the surgery. So we have to assess that. In some conditions where the patient might have like a stent that has been recently put in and that requires to be on or depending on the indication and on the risk of stopping aspirin, then we need to advise.
Okay. Okay, that's good. It brings us to the end of the Viva. You ran for almost 25-30 minutes. Good, well done. Okay, I'm going to cut the call now, and we're going to run another Viva, and then I'm going to go through the answers at the end. Okay, stay tuned. Thanks, bye. Hello.
Hi, Mr. Raju.
Hey, Vusi, how are you?
I'm okay, thanks. How are you doing?
Fine, thanks. Shame you're struggling a bit there.
Yeah.
Sorry to hear that you're unwell. Um,
Oh, sorry. Which one do I switch off again? Can I hear?
switch off the YouTube sound, the sound on YouTube.
Okay, okay. 100% it's off.
Oh, okay, good. So we are going to run a Viva. This is more sort of surgical pathology questions.
Okay.
Okay, so if you can just adjust your camera, we can't see your eyes. That's it. Okay, so your first question related to breast cancer. What are the risk factors for the development of breast cancer?
Okay. Not sure if you can see me.
Okay, don't worry too much about it. Can you see the slides on YouTube?
Okay. So the risk factor, I can see.
Okay.
The risk factor in development of breast cancer include basically one, family history of breast cancer,
Mm-hmm.
previous radiation, genetic factors like BRCA genes, BRCA1, BRCA2.
Mm-hmm.
Usually, if you've had other cancers like ovarian cancers, also some are risk factors.
Okay.
And what else? Yeah, I think those are the main things that I can think of right now.
Okay. Does South Africa have a breast cancer screening program?
As far as I know, we don't have a particular breast cancer
Yeah, we don't.
like in
That's
the UK and other areas.
okay. Good. So in the UK, can you tell us a little about an ideal breast screening program that we would like to implement, such as that running in the UK in the NHS?
I'm not sure if there is a particular one, but I know that they use, or in the literature, they use something that is called the GREEN model.
Mm-hmm.
Basically, just particular factors that we run through, like the risk factors that you've mentioned,
Mm-hmm.
and the patient gets a point for each. And mainly it has to do with how would you progress with that particular patient, like what would be your next step, like in particular with how would the patient be screened, like how would that patient be either the particular mode of screening would be the patient for serial examination, when the patient gets an ultrasound. Usually if they are high risk patient, they go to an MRI of the breast.
Mm-hmm.
So
So obviously, screening programs have to cover a wide number of patients, and they have to be relatively cost effective. To what are the age cutoffs, and what are the parameters or the mechanisms of actually screening?
I forgot about the other risk factors, age and females.
Mm.
So the age cutoffs, I think, usually we use 35 to 40
Mm-hmm.
as high risk patients. In other areas, they say up above 40 to 45 in high risk areas. So, but as far as I understand, I think it has come down now to 35 to 40. And those patients usually get an ultrasound with mammogram.
Mm-hmm.
And obviously, we say the older patients, because of the breast density, they get a mammogram, and the younger patients usually get an ultrasound. But of course, right, currently we are using both modalities for screening.
And age, oh yes, you said 35 to 40. Okay,
Yes.
that's fine. Good. Going to move on now. No problem. How is breast cancer diagnosed?
Okay, so breast cancer basically we use what is called triple assessment to
Mm-hmm.
diagnose breast cancer, which includes examination, good examination of the breast, all the four quadrants, with both hands, and then palpate the axilla. Okay, and then you characterize the lesion that you find: solid, cystic, soft, tender, non-tender.
Mm-hmm.
And of course, you must examine the nipples as well. And then followed by imaging, which is usually in the form of ultrasound and mammogram.
Mm-hmm.
And then with that, usually we're going to do a tissue. So we did a biopsy with that. So FNA is currently not advised. So what we use is a core or an open. Actually, we use a core biopsy, but we need histology more than anything.
Okay, good. How is breast cancer classified?
So breast cancer is classified as early and late and metastatic.
Mm-hmm.
Basically, it depends. We go according to the TNM classification. So it depends on the size of the breast, it depends on the lymph node involvement, and it depends, of course, if there's metastasis or no metastasis.
Mm-hmm.
So usually we say from up to T2N0 or T2 is still early breast cancer. Above T2 with nodal involvement, usually we say it's late, and then you have metastatic breast cancer, depending on if there's extra breast spread of the tumor.
Okay, that's fine. Easy question. What do you understand by the terms level 1, 2, and 3 auxiliary clearance?
So level 1, 2, and 3 auxiliary clearance, we're talking about the levels of the lymph node distribution in the axilla. So basically, we use the pectoralis minor muscle. So below the pectoralis minor is level 1, posterior to the pectoralis minor is level 2, and above and medial is level 3.
Okay.
That clearance.
What do we usually do with breast cancer? What level?
So we usually do level 2, up to level 2. So posterior to the pectoralis minor. We don't go above. There is a modification that takes down the pectoralis minor and goes for breast, but it's not usually done. I can't remember the name. And usually for melanoma we do up to 3, but for breast we only do up to 2.
Correct. Good. What are the surgical options in the management of breast cancer?
So the surgical options in the management of breast cancer, one is the one that we prefer to use is breast preserving procedures. Basically, we try to, so you can have breast preserving, you can have mastectomy, you can have a bilateral, like an on-call BBR, depending on the size, of course, of the breast, and depending on the risk profile of the patient, and depending on if you have radiation or not in your and depending on the size of the breast of the patients. I
Okay.
don't want to answer a question before you ask. So,
Okay, that's fine. What do you understand by the term skin-sparing mastectomy?
okay, so a skin sparing mastectomy is usually it's a mastectomy whereby a skin sparing mastectomy is a mastectomy whereby basically you take the whole breast tissue, but you leave the overlying skin. Usually do it here with the assistance of the plastic surgeon. So basically what you do, you make a small if I can say, usually by the nipple areola complex, and then you open, and then you try and scoop all the breast tissue around the
Okay.
skin, and then just leave the skin, and usually you're gonna have to replace it with something.
Okay, good. That's fine. What do you understand? You already mentioned this breast, you said breast preserving. It's actually breast conserving surgery.
Yes,
So what does this actually mean? Just tell me a little bit more about it.
So breast conserving surgery is basically breast conserving surgery is basically surgery whereby you try to conserve breast tissue. So it's opposite to a mastectomy, you just do a lumpectomy, if I can put it like that. Okay, it can be done with or without an axillary clearance, but it must always be done with radiation.
What is a better term? You said lumpectomy. What would be a better term to describe? Yeah.
Excision of the excision of the lesion without a mastectomy. I think it's a while, but yeah, I can't remember the better term at all. I'm not sure which one you're looking for.
Wide local excision.
Wide local excision.
Okay. What are the indications for mastectomy?
So in malignant, in cancer, or just in general?
No, in cancers. In cancers.
Okay, so you're asking for the indication for mastectomy in opposite to breast conservative surgery. Okay, so the indication for mastectomy one is a tumor that is too big for the breast, or a breast that is too small for the tumor. So if you can do breast conservative surgery, basically. So if I can say, let me just say the indication for mastectomy is when you can't do breast conservative surgery. One, that would be if the patient is a previous radiation, if the patient is currently pregnant, if the patient has a tumor that is too big for the breast, if the patient has got if the patient refuses breast conservative surgery, so patient's consent. Okay, also inflammatory breast cancer. Yes. What are the other indications? I think there's 5 or 6 indications.
Oh, okay, that's fine. Which nerves are in danger of being injured during a mastectomy?
So the nerves that are in danger of being injured, one is the long thoracic nerve, the thoracodorsal complex, and the intercobrachial nerve.
Anything else? Yeah, that's correct. Any other nerve? There's one more nerve.
Intercostal.
You said that, intercostobrachial.
Intercostobrachial, and
as you come around the lateral edge of pec major.
brachial, not brachial, I'm not sure. It's right.
Oh, okay, it's fine. What do you understand by the term sentinel node? How do you define a sentinel node?
So a sentinel node is the first node that is responsible for drainage if you're talking about the axillary, first node that is responsible for drainage of the breast. So basically, when you're doing a sentinel lymph node biopsy, it's the first node that will highlight. And so it's the first node, and it's the node that should be taken for the sentinel lymph node biopsy. And if it's involved, we take it that there has been axillary spread of the tumor.
Oh, okay, good. What is the role of adjuvant chemotherapy in breast cancer?
So the role of adjuvant chemotherapy in breast cancer, basically, one is to try and improve survival, improve outcome, and decrease recurrence. So we usually use it in patients that have got stage, let me say, that have got, we usually use the TNM classification also. We use it in patients that have got, usually we would say T3 to T4 and above, and if they've got axillary lymph node involvement. And those patients usually should get adjuvant chemotherapy. And it's mostly usually patients that will get a mastectomy, but like I said, usually patients also with breast conservative surgery can get adjuvant chemotherapy. Sometimes you can also use it in patients that have bigger tumors, but they want breast conservative surgery to decrease the tumor, and it might decrease the tumor, and the patient will be amenable for breast conservative surgery. Some of these patients may actually get complete pathological response. So unfortunately, some of those will have to end up with a mastectomy unless if you had wired them or if you had marked them before.
Okay, good. Can you name me a few combinations, the chemotherapy combinations that we use?
Okay, so usually
just one or two.
There's EF and then there's ACS.
Mm-hmm.
And then usually there is also CE that you can use,
Mm-hmm.
but ACS usually is used for like elderly patients.
Mm-hmm.
And then of course now we are starting with platinum, like we've got Texas, so Texas that is starting to include now that we're starting to use.
Okay, good. We're going to move on now. What is the clinical presentation of carotid artery stenosis?
Clinical presentation, usually these patients might present one with a CVA.
Mm-hmm.
They might present with signs and symptoms of a new stroke.
Mm-hmm.
So basically hemiparesis, confusion, pupillarity.
Okay, CVA is fine. What else?
They might have headaches. They might have postural hypotension, I think. I don't know. What else can they have? I can't think of anyone. I know the most common is stroke.
Okay, well, how can stenosis be assessed?
Okay, so assessment of the carotid artery stenosis includes a Doppler ultrasound imaging. Usually we use the Doppler ultrasound to assess.
Mm-hmm.
And then you can also use a CT angio to assess carotid artery stenosis.
Mm-hmm.
And then you can classify it and classify the stenosis or grade, so you can grade the stenosis and decide if the patient needs intervention or not.
What about clinical assessment?
And okay, so on clinical assessment, yes, there is clinical assessment. I'm not sure if you're gonna feel a bruise or you're gonna feel calcifications clinically.
Mm-hmm.
But I don't. But as far as I know, I don't think I know there is some clinical assessment, but I'm not sure if it's as effective or as accurate as imaging, because all these patients eventually end up having imaging.
Okay, what is the non-operative treatment of carotid artery disease?
Non-operative treatment of carotid artery disease.
Mm.
Okay, so non-operative treatment includes one, antiplatelet therapy.
Mm-hmm.
So we might use aspirin.
Mm-hmm.
We might use clopidogrel, and sometimes the patient can be put on Warfarin.
Okay. What are the indications for surgery?
Okay, so indications for surgery for these patients. I know there's ASA guidelines.
Mm-hmm.
So they look at the one, the grade of the symptoms started. Is it more than 6 months? Is it less than 6 months?
Mm-hmm.
So they say if the stenosis is more than 50%, 60%, that is one of the indications for surgery. And then they look at the type of, also, like I said, type of the thrombus or type of the calcification.
Mm-hmm.
If they check if it has got like capabilities of dislodging, and then I just can't remember what they classify it as.
Mm-hmm.
But it's also one of the indications for intervention. And also patients who are symptomatic, but they also look at the duration of the symptoms. When the patient started having symptoms, according to the ASA guidelines, and then those patients, and then they decide if those patients should get intervention or not. So that's an idea. I just can't, I can't tell you the exact thing. I looked at it a long time ago.
Okay, we'll give you a break because you're suffering from bad flu. Okay, let's move on. We spoke about the indications. Now, what are the surgical treatment options available?
Okay, so surgical treatment options, you can have open or endovascular treatment.
Mm-hmm.
So open treatment is usually a carotid endarterectomy. Basically, you take out the thrombus from the patient, you open the vessel, take out the thrombus.
Mm-hmm.
And then endovascular is basically an endovascular stent.
Okay.
Like I said, it's endovascular, and then they dislodge a stent to open up the patient,
Okay.
to open up the carotid artery.
Okay, good. And then last is, how can cerebral function be monitored in a patient undergoing carotid endarterectomy?
So they do something called, I can't remember the name. We do something whereby they basically put a probe, I think, and they measure it, and then they measure the perfusion, and then it's basically used to decide if the patient will need a shunt during the operation or not. So if the cerebral function we think is going to be compromised, then usually we shunt those patients during the procedure. But if you don't think it's going to be compromised, then usually we don't shunt. You can do the endarterectomy or the bypass without shunting the patient.
Okay. What about, have you ever seen this procedure being done under local anesthetic?
I have heard of it, Mr. Raidu. I've just never seen it being done. Actually, I've only assisted in one. Actually, in my whole lifetime, and endarterectomy.
These are not the things I want to hear. Okay, this procedure can be done under local, okay? You need to bear that in mind. So
Yes.
that obviously allows you to assess the patient's mental status intraoperatively. The anesthetist can actually speak to the patient. That's the advantage. Okay, good.
I've seen them on the internet.
Okay, good. So that brings us to the end of your Viva. Sorry you're feeling so sick, but you've soldiered through it. Well done. I'm going to cut the call now, then I'm just going to run through the answers for both sets of Vivas. Okay, bye. Sure, bye. Okay, we're going to now run through the answers. So, firstly, what are the indications for surgery in patients with AAA? Our candidate didn't actually separate out the answer into emergency and elective. So, if it ruptures, and secondly, I also considered an emergency repair if it's rapidly expanding at more than 1 centimeter annum, and the aneurysm is symptomatic or clinically tender. Okay, symptomatic usually means abdominal pain, epigastric pain, or pain referred to the back. And then clinically, if you touch the expansile mass, and it is tender. Elective repair, generally aneurysms greater than 5.5 centimeters in diameter, symptomatic aneurysms, and the rate of expansion of more than 1 centimeter a year that are asymptomatic and non-tender as opposed to the emergency repair parameter which was mentioned above. How should patients with smaller aneurysms be managed? These questions seem to be throwing the candidates a lot. It's just what are you going to do with these patients? What are you going to tell them, and what are you going to do? So it's really just got to do with follow-up or surveillance, less than 4 centimeters, annual ultrasound surveillance. 4.4 to 5.5 centimeters should rather have 6 monthly ultrasound surveillance. What are the surgical options in the treatment of AAAs? And briefly discuss the 2 options and list post-procedural complications of each. Right? So this, you can see, is quite a lot of information required here. The 2 categories are endoluminal repair and open repair. Right? Endoluminal repair may be done transfemoral or transiliac placement of prosthetic graft under fluoroscopic guidance. The 3 main types of grafts are aorto-aortic, aorto-biiliac, and aorto-uniiliac, with the fem-fem crossover. This usually requires a CT angiogram or IADSA. IADSA is actually intra-arterial digital subtraction angiography to evaluate the morphology, and you must bear in mind there's certain parameters. You require about 1 to 1.5 centimeters of healthy aorta distal to the renal arteries. 1 centimeter in the common iliac artery is required for sufficient clearance. Therefore, only about 40% of aneurysms are suitable for this type of repair. Okay, then I'm running out of time, so I'm just going to skip through this. These answers will be available to you on teachable.com. The complications in Viva include graft migration or displacement, graft occlusion, infection, embolization, and graft kinking, as well as endoleaks, which can actually lead to ruptures. Open repair, immediate complications, bleeding, embolism, and arterial thrombosis. Early complications are acute renal failure, CVA, MI, mesenteric infarction, spinal cord ischemia. Late complications, graft infection, false aneurysm, and aortoenteric fistulae. Okay. Next question. When is it safe to perform surgery in patients on warfarin? Simple question, INR less than 1.2. Some may use a value of 1.5, but 1.2 would be safer. How should patients on warfarin be managed prior to elective surgery? So warfarin should be stopped 4 to 5 days before surgery. You could start with an intravenous heparin infusion. We are more likely to use low molecular weight heparin. And if you are using heparin infusion, you'd use APTT to monitor. How should patients on warfarin be managed during emergency surgery? Preoperatively, 10 milligrams of IV vitamin K is given, followed by fresh frozen plasma. The medication available from the blood bank, which I was asking about, is a product called Hemosolvex. Problem with vitamin K, it causes a problem or resistance to rewarfarinization. This was a bit of a tricky question. Is it important to measure low molecular weight heparin activity? No. You can measure it using factor 10A levels, but this is not required, as the bioavailability of low molecular weight heparin is far more predictable than for regular heparin. What is the effect of antiplatelet agents on surgery? Once again, nothing complex. It makes the patient prone to bleeding, and this can be a special risk in, for example, neurosurgical procedures, and the trick is to merely stop this a week or 10 days prior to surgery. Right? And obviously you can monitor the bleeding time before proceeding to surgery. Next question. Let's just read and ask that. Okay, what are the risk factors for the development of breast cancer? Right, you must always mention female more than male, age, older age group, 5th decade, family history. Obviously, this is extremely common in families. Age, the age of birth of the first child, number of children, early menarche, late menopause, all related to estrogen window and estrogen exposure. Then you should not forget genetic predisposition, things like Cowden disease, Muir-Torre syndrome, BRCA1 and 2, also less commonly Li-Fraumeni and Peutz-Jeghers. Non-invasive carcinomas in situ and ductal carcinoma in situ, lobular carcinoma in situ that were picked up on a previous biopsy are risks for active breast cancer. Benign proliferative changes with atypical hyperplasia. This may be picked up on biopsy. And going on to screening program, South Africa does not have a screening program. What is an ideal breast screening program? Guys, you need to have an understanding of this. Breast cancer is extremely important to screen. Right? Screening relates to the general population. You don't necessarily have to identify high risk individuals. In the UK, women between 50 and 70 have 3 yearly mammograms. Mammograms taken in 2 views, craniocaudal and then mediolateral. If any abnormality is seen on mammogram, then the patients are recalled for a triple assessment. Mammograms are not as effective in premenopausal women because of the density of the breast tissue. This makes it more difficult to detect problems. And then the average age of menopause in the UK is 50. As women go past menopause, the glandular tissue in their breast involute, and the breast tissue is made up increasingly of only fat, which is clearer on the mammogram. Right, so it's very important to have a understanding of what a screening program should be like. How is breast cancer diagnosed? Triple assessment. Our candidate covered that well. How is breast cancer classified? This is a little bit tricky. You don't want to go overboard, but bear in mind that there's epithelial tumors, which are the ductal and lobular. Then you get non-invasive, invasive. Then you get mixed connective tissue tumors, mixed and epithelial, such as phylloides tumor. People tend to forget about phylloides. It's actually considered to be malignant. And then obviously the primary lymphomas. Okay. Level 1, 2, and 3 axillary clearance is in relation to PEC minor. That was well explained. Surgical options in the management of breast cancer. Now, there's a lot of surgical options available, so you mustn't lose marks by forgetting things like a ductal excision. If you have a bloody nipple discharge, you might actually do a ductal excision, and on that excision you find malignancy and you may need to proceed further. Wide local excision or lumpectomy, which is breast conservative. Quadrantectomy, also breast conservation. Total or simple mastectomy, then the modified radical mastectomy, which is what we typically do. And modified radical mastectomy includes a level 2 axillary clearance. Then skin sparing mastectomy. This is not commonly seen, but it is practiced extensively, as our candidate mentioned, together with plastic surgeons. Right? It's not exactly the same as a subcutaneous mastectomy. These terms are not interchangeable, although it's typed out here in the answer. Subcutaneous mastectomy is typically used to mastectomy is followed by an immediate breast reconstruction. What do you understand by the term breast conserving surgery? This is a term described to use lumpectomy, quadrantectomy, or segmental mastectomy. The term lumpectomy I'm a little concerned about. I would prefer to use wide local excision. We must mention that there is always a need for adjuvant radiation therapy because there is breast tissue being left behind, and there's a possibility of cancer cells thus being left behind. What are the indications for mastectomy? Right? When would you do a mastectomy as opposed to breast conserving surgery? If there's multifocal disease, if there's extensive DCAs, male patients never have breast conserving therapy, they always have mastectomy. Our candidate mentioned tumor size in relation to breast. Patient may choose mastectomy over breast conserving therapy. If the tumor is central, it may not be possible to do a wide local excision. and then salvage surgery. Which nerves? Thoracodorsal, long thoracic, intercostobrachial. Just bear in mind the lateral and medial pectoral nerves, and the brachial plexus can be injured in extreme cases. Sentinel lymph node, I think that's fairly straightforward. First lymph node in the drainage basin, and we use radioisotope and color dyes to try and identify this initial lymph node. Role of adjuvant chemotherapy in breast cancer, we need to just bear in mind that adjuvant chemotherapy actually includes neoadjuvant, right? So people tend to be a bit confused and think that adjuvant chemotherapy is on one side and neoadjuvant is on the other side. What we should actually do is consider adjuvant chemotherapy as a heading, and below that we would include as a type of adjuvant chemotherapy neoadjuvant, which is chemotherapy that's given before surgery. Okay, so it's still an adjuvant type of chemotherapy. However, it is given preoperatively, therefore it has its own name, which is called neoadjuvant, but it is still a type of adjuvant chemotherapy. Commonly used regimens, CMF, cyclophosphamide and methotrexate and 5-FU, FEC very common, epirubicin, cyclophosphamide and 5-FU. And then also adjuvant, okay, here they've mentioned tamoxifen. We classify tamoxifen as hormonal therapy as opposed to chemotherapy, but certain terminology, because it is a chemical as such, it is considered under the heading of chemotherapy. Okay, then we went on to a bit of a tricky question on carotid artery stenosis. Okay guys, this is bread and butter to the vascular surgeons. If you happen to get a vascular surgeon, they can ask you these tricky sort of questions. So you don't need to know details of how to perform this operation, but certainly the surgical pathology surrounding coronary artery stenosis, carotid artery stenosis, you must know. Clinical presentation, candidate mentioned CVA. It may be evolving, it may be complete, there may be asymptomatic bruit, TIAs and RIND, very common. And then amaurosis fugax, this temporary blindness. Patients lose sight in one or both eyes, and then it suddenly returns when the blood flow improves. Assessment of the stenosis, if you have a broad question like that, always start with clinical assessment, right? Then we move on to duplex imaging, CT, MRI, angiography, etc. And then transcranial Doppler can also be used to assess cerebral reserve. What is the non-operative treatment of carotid artery disease? Guys, it's the same as non-operative treatment of patients with peripheral vascular disease, right? Lifestyle modification, optimization of medical comorbidities, modify risk factors, stop smoking, tight diabetic control, tight hypertensive control. Okay, and then our candidate did mention prophylactic aspirin. Okay, what are the indications for surgery? This can be very confusing. You must sit down and work it out very clearly in your mind and not get confused. Okay, so there's two trials that are the basis for the indications for surgery: the NASCET trial, North American Symptomatic Carotid Endarterectomy trial, and the ACAS, which is the asymptomatic carotid atherosclerosis study. So under the symptomatic, going back up here, right, patients with stenoses of 70 to 99% benefit. There is no benefit if there's less than 70% stenosis. Perioperative risk of stroke or death was 5.8%. Angina and hypertension should be well controlled. For asymptomatic patients, in patients with more than 60% stenosis, the risk of ipsilateral stroke over 5 years is reduced with surgery and medical treatment compared with medical treatment alone. Okay, so these are the things that you should have clearly in your mind. Surgical treatment options, basically open and close carotid endarterectomy, which can be done under local or general, and then angioplasty and stenting. Right? How can cerebral function be monitored in patients undergoing carotid endarterectomy? If the patient is having their procedure done under local anesthetic with the patient awake, the anesthetist can actually keep talking to the patient, and you can actually clinically assess whether their cerebral activity is normal. Right? Other than that, if the patient is under GA, then you might need transcranial Doppler, EEG, transcranial PO2, and then there's stump pressure measurement, which our candidate mentioned. Okay, it was quite difficult surgical pathology vivas, but this is an indication of what you need to be prepared for. And I will send out the answer sheets to these vivas, and I will also post these videos to, I will send you a link, YouTube link for those who might have missed this. Thank you very much, everyone. Good night.